Hello students, in today's video we are going to discuss treatment of gout. We will study pharmacology of anti-gout drugs. Now in order to understand treatment, it is important to quickly revise pathophysiology of gout. Gout is a disorder of purine metabolism. Now as we know, purines are nitrogenous bases, namely adenine and guanine. Now these purine bases are used for synthesis of nucleotides. And these nucleotides are further required for the synthesis of DNA and RNA. So, gout is a disorder of purine metabolism. Now, when these purines break, they produce uric acid. Now, excess uric acid in the blood, that is hyperuricemia, causes gout. Now, at physiological pH of 7.4, uric acid exists as urate ions. Now, normal plasma urate concentration is 2 to 6 mg per deciliter. If serum urate concentration exceeds 6.8 mg per deciliter, then these urate ions, they become insoluble in the plasma and they bind to sodium ions to produce monosodium urate crystals. And these crystals deposit in the joint that produces gout. So, gout is a disorder of purine metabolism. It is characterized by hyperuricemia and deposition of monosodium urate crystals in the joints, bones, soft tissues and kidneys. Now, very important, let's discuss clinical manifestations of gout so as to understand its treatment. Now, gout is broadly manifested as acute recurrent gout attacks and chronic tophaceous gout. Now, let's first understand what is acute recurrent gout attack. Now, it can also be termed as flare-up of gout disease. That is, symptoms of gout like pain, swelling, they flare up. Intensity of these symptoms increase, and as the severity of gout increases, frequency of these attacks also increases. So these attacks are termed as recurrent attacks. Now look at this figure of synovial joint. Now hyperuricemia induces formation of monosodium urate crystals. These crystals, they deposit in the joint and induce severe inflammation and pain. So acute gout attack is characterized by sudden onset of very severe pain and swelling in the joints. Now, base of the big toe, that is metatarsophalangeal joint, is the most commonly affected joint in the gout. Now, initially gout attack is monoarticular, that is, it is confined to one joint only. Now, these attacks, they normally resolve themselves within 3 to 14 days, and thus these acute gout attacks are self-limiting. Now, goal of the therapy in the management of acute gout attacks is to reduce pain and to reduce swelling or inflammation. So, NSAIDs and drugs like colchicine, corticosteroids are used in the management of acute gout attacks. Now let's understand chronic tophaceous gout. This is advanced chronic gout, and it takes more than 10 years for chronic gout to develop after an initial acute attack of gout. Now pain and swelling becomes chronic, that is, pain and swelling becomes long lasting. And now the gout is not confined to one single joint. The gout becomes polyarticular and a number of joints get affected like the knees, ankles, wrist, elbows. Now in addition to chronic pain, the gout attacks also become frequent. Now if it further progresses, it can cause disability and deformity of the joint. Now look at this figure. This figure shows chronic tophaceous gout. Now, chronic tophaceous gout is characterized by the deposition of tophi in the joints. Now, this is a single tophus. Now, these are monosodium urate crystals in the center. Now, these crystals are surrounded by the inflammatory cells like macrophages and neutrophils. Now, chemicals like cytokines, lysosomal enzymes are released by the inflammatory cells. And these cytokines and enzymes, they destroy the articular cartilage, they cause destruction of the bone, and they also cause destruction of the synovial membrane. So, chronic gout is treated by reducing the concentration of uric acid in the blood. So, drugs like allopurinol that inhibits synthesis of uric acid, and drugs like probenecid that increase the excretion of uric acid are used in the management of chronic gout. So now let's discuss treatment of gout. Now there are two aspects of treatment: managing an acute attack. Here the main goal of therapy is to reduce pain and inflammation of joints. And second is the prevention or prophylaxis of chronic gout. Now chronic gout is treated by reducing concentration of uric acid in the blood. Now drugs that are used to treat acute gout are NSAIDs, that is non-steroidal anti-inflammatory drugs. For example, naproxen, piroxicam, diclofenac, indomethacin. Now these are first line drugs for the management of acute gout attacks. Second line treatment is done by the use of colchicine. Now colchicine specifically suppresses gouty inflammation. Now third line therapy is with corticosteroids, for example prednisolone. Now steroids are very potent anti-inflammatory agents, but these are not preferred because of their wide spectrum of side effects. Now drugs that treat chronic gout are drugs that reduce synthesis of uric acid, that is synthesis inhibitors. Now allopurinol is a first choice drug for treating chronic gout. Another drug that reduces synthesis of uric acid is the febuxostat. Now second category of drugs are uricosurics. Now these drugs increase excretion of uric acid by the kidneys. For example, probenecid. Another new drug is the rasburicase. It is a recombinant uricase. Now rasburicase converts uric acid to allantoin, and allantoin is more water soluble and it is readily excreted from the kidneys. Now major problem associated with the rasburicase is the hypersensitivity. It can cause anaphylaxis, which might limit its use in the treatment of gout. Now in addition to the use of drugs, certain lifestyle changes reduce the risk of developing gout. So stay well hydrated and drink plenty of water. Now hydration reduces precipitation of monosodium urate crystals. And apart from this, keep oneself fit by exercising, because exercises reduce obesity and that further reduces the risk of gout. Now in addition to this, minimize high purine diet that produces increased uric acid, because when the purines break, they produce uric acid. Now reduce consumption of red meat, reduce consumption of seafood. Now apart from this, minimize consumption of alcohol, then high fructose drinks and caffeinated drinks, because consumption of alcohol and caffeine causes dehydration, which causes the precipitation of monosodium urate crystals, and high fructose drinks increase the production of uric acid in the blood. So these are the drugs that are used for the treatment of gout, and these are certain lifestyle changes that can reduce the risk of developing gout. Now let's discuss pharmacology of these drugs in detail one by one. Now let's first discuss treatment of acute gout. Now goal of the therapy in the treatment of acute gout is to reduce pain and to reduce inflammation or the swelling of the joints. Now as already discussed, NSAIDs are the drugs of first line therapy in the management of acute gout attacks. Now NSAIDs include drugs like naproxen, piroxicam, diclofenac. Now NSAIDs are very strong anti-inflammatory agents. They show strong anti-inflammatory action, and these drugs are very effective in reducing pain, as well as inflammation. And these drugs terminate acute gout attack within 12 to 24 hours. And NSAIDs are better tolerated than colchicine. But caution should be exercised when these drugs are given to patients with renal insufficiency and also in patients with peptic ulcer disease. Now, second line therapy for the treatment of acute gout is the colchicine. Now, colchicine is neither an analgesic nor it is an anti-inflammatory agent, but colchicine specifically suppresses gouty inflammation. It has a very important role, a very specific role in reducing inflammation because of the gout. Now, as we know that in gout, monosodium urate crystals deposit in the joints and induce inflammation. Now, chemotactic factors that attract immune cells are produced by these joint tissues because of the deposition of these crystals. Now, because of the production of chemotactic factors, neutrophils, they migrate in the joints, and these neutrophils, they further aggravate the process of inflammation. Now, main function of colchicine is to inhibit movement or migration of neutrophils in the inflamed joints. So, colchicine inhibits the migration of these neutrophils in the inflamed joints. Look at this figure. These are microtubules. Now, as we know, these microtubules are responsible for cell movement. Now, microtubules are made up of microtubular protein that is called as tubulin. Now, tubulin is made up of alpha and beta subunit. Now, colchicine binds to these fibrillar proteins in the microtubules and break or disrupt these microtubules. So, as shown in the figure, microtubules break and separate into tubulin. So, movement of neutrophils is inhibited. Now, neutrophils are unable to migrate in the inflamed joints. So, there is inhibition of chemotactic and chemokinetic responses. So, migration of neutrophils in response to release of inflammatory mediators, that is cytokines, is inhibited. So, now the neutrophils do not migrate in the inflamed joints. So, and apart from this, there is further inhibition of release of cytokines, chemotactic factors, glycoproteins, proteinases enzymes by the neutrophils. So, now the neutrophils on one side, they cannot migrate into these joints, and secondly, they do not release these inflammatory mediators. So, this causes suppression of gouty inflammation. So, now neutrophils can no longer aggravate and enhance the inflammation. Now, unlike NSAIDs, colchicine is fast acting. If it is given within 24 hours of acute attack, colchicine terminates the acute attack within hours. Now, let's talk about the toxicity of colchicine. Now, toxicity of colchicine is high and it is dose related. Now, very common side effect of colchicine is the gastrointestinal upset. Colchicine produces nausea, vomiting, watery or bloody diarrhea, abdominal cramps. Now, chronic therapy with colchicine produces bone marrow depression, aplastic anemia, agranulocytosis, myopathy, and it can also cause loss of hair. Now, third line therapy for the management of acute gout attacks is the corticosteroids, for example, prednisolone. Now, intra-articular injection of soluble steroids, that is injection within the joint, injection within the inflamed joint, suppresses the symptoms of acute attack. Now, steroids are indicated in refractory cases, that is those gout cases that do not respond to NSAIDs or colchicine. Now very important to remember that when steroids are to be stopped, they should be discontinued gradually. So dose should be gradually tapered. So for the treatment of acute gout attack, first line therapy is the NSAIDs, then colchicine, and corticosteroids are used for refractory cases not responding to NSAIDs and colchicine. After treatment of acute gout attacks, let's discuss treatment of chronic gout, that is prophylaxis of gout, or how to prevent gout. Now gout is caused because of hyperuricemia. So these drugs reduce uric acid level in the blood. Now first category of drugs that reduce hyperuricemia are xanthine oxidase inhibitors. Xanthine oxidase inhibitors, for example allopurinol, febuxostat. Now as we know, uric acid is the breakdown product of purine nucleotides like adenosine monophosphate, AMP. Now look at this figure. Now it depicts breakdown of purine nucleotides and the formation of uric acid. Now when the purine nucleotides break, hypoxanthine is produced. Now enzyme xanthine oxidase break hypoxanthine to xanthine and further break xanthine to uric acid. So enzyme xanthine oxidase is required for the synthesis of uric acid. Now allopurinol and febuxostat are the xanthine oxidase inhibitors. So these drugs, they inhibit the enzyme xanthine oxidase, thereby inhibiting the synthesis of uric acid. Now since the production of uric acid is reduced, this reduces concentration of uric acid in the blood. Now allopurinol is a first choice drug for the treatment of chronic gout. Now look at this reaction. Allopurinol is a competitive inhibitor of enzyme xanthine oxidase. Half-life of allopurinol is 2 hours. Now allopurinol is metabolized in the body to alloxanthine. Now alloxanthine is a non-competitive inhibitor of xanthine oxidase. So alloxanthine also reduces synthesis of uric acid in the body. Now alloxanthine is primarily responsible for reducing uric acid in the blood. Now see to the half-life. Half-life of alloxanthine is 24 hours. It's very long acting. Now with long-term allopurinol therapy, blood uric acid reduces and tophi also gradually disappear from the joints. Now very important, plenty of water should be given with these drugs to facilitate rapid excretion of hypoxanthine and xanthine. Now since there is inhibition of synthesis of uric acid, hypoxanthine and xanthine, they accumulate in the urine, and plenty of water should be given so that hypoxanthine and xanthine are easily excreted. Now apart from this, these drugs along with the uricosuric drugs like the probenecid should not be started during acute attack of gout, because these drugs can cause removal of uric acid from the tophi, which can cause increase in the blood uric acid levels and which can further aggravate the attack of gout. So therapy with these agents should be started only after the acute attack is terminated. Now allopurinol can cause hypersensitivity reactions like skin rashes. Now rarely allopurinol can cause Stevens-Johnson syndrome. Now allopurinol is contraindicated in pregnancy and lactation. Now febuxostat is an alternate drug in patients intolerant to allopurinol. Now most important adverse effect of febuxostat is the liver damage. Now usual side effects of febuxostat are diarrhea, nausea and headache. Now these drugs, that is allopurinol as well as febuxostat, they inhibit metabolism of 6-mercaptopurine and azathioprine. So doses of these drugs should be reduced when given with xanthine oxidase inhibitors. So this is how allopurinol and febuxostat reduce synthesis of uric acid and are found to be very useful in the treatment of chronic gout. Now, second category of drugs for the treatment of chronic gout are uricosuric drugs. Now, these drugs increase excretion of uric acid in the urine. Now, most important drug in this category is the probenecid. Now, probenecid is the second line drug for the treatment of chronic gout, and it is also used as an add-on or adjuvant drug to allopurinol. That means it is also used along with allopurinol. Now, look at this figure. Now, this figure shows a nephron. Now, nephron, as we know, is the functional unit of kidney. Now, this is the first part of nephron, and it is termed as proximal convoluted tubule. Now, these are the cells of proximal convoluted tubule. Now, uric acid. Uric acid is predominantly excreted by the kidneys. So, uric acid is filtered by the process of glomerular filtration. So, uric acid is filtered in the lumen of the nephron. Now, 10% of the uric acid is excreted in the urine, while 90% of the uric acid is reabsorbed in the cells of proximal convoluted tubules. Now, this reabsorption of uric acid is mediated by a transporter. The transporter here shown in the yellow color. So, this transporter is the URAT1. So, URAT1 is the transporter which is responsible for the reabsorption of 90% of the filtered uric acid in the cells of proximal convoluted tubule. Now, probenecid is a highly lipid soluble organic acid, and probenecid is a competitive blocker of URAT1. So, probenecid blocks this transporter, that is URAT1, thereby inhibiting or thereby blocking the reabsorption of uric acid in the cells of proximal convoluted tubule. So, blockage of this URAT1 transporter by the probenecid prevents reabsorption of uric acid, and therefore, this uric acid, instead of being reabsorbed, this 90% uric acid is also excreted in the urine. So, probenecid increases the excretion of uric acid in the urine. So, this is the mechanism by which probenecid increases excretion of uric acid, thereby reducing the blood levels of uric acid. Now, since it is increasing excretion of uric acid, probenecid is ineffective in renal insufficiency. Now, since excess of uric acid is excreted in the urine, plenty of fluids should be given to the patients to prevent urate crystallization in the urinary tract. Now, as discussed with the allopurinol, probenecid should not be started during acute attack of gout. Now, probenecid is generally well tolerated, but the most common side effect is dyspepsia, that is indigestion, and rarely probenecid produces hypersensitivity. Now, probenecid shows a number of potential drug interactions. It inhibits urinary excretion of penicillins, cephalosporins, sulfonamides, methotrexate, indomethacin. Apart from this, aspirin blocks uricosuric action of probenecid. So, this is in brief on the pharmacology of probenecid, and this is all about the pharmacology of drugs used for the treatment of acute and chronic gout. Please note that the information provided in this video is meant exclusively for the students from their examination point of view. For the treatment of gout, consult your physician. If you find the video useful, kindly like, subscribe and share this video. Thanks for watching this video.